All right, just a little bit of anatomy to go, and then we move into reproductive disorders. This is Dr. DeShavo. We are in part 3 of chapter 8. In the mammary glands, both males and females have these mammary glands, but only the females produce milk. If a male has secretion from his nipple, though, he still should be checked for breast cancer, as males can form cancerous tumors in their breasts. So, little side note, and I'm sure you probably already know that. Same thing with a female. If she is a non-lactating female and she is having something come from her nipple, she should be checked as well. That's bread and butter stuff. I know you guys know that. Now, if a woman becomes pregnant, the hormones that come into play with the creation of and letting down of milk, prolactin, just as it sounds, prolactation, is a hormone. This is also from the anterior pituitary, that little amazing gland in the center of your brain, and this causes milk production. So this is what helps the breast create and store milk. We actually store milk high in the breast, in the lobes of the breast. Oxytocin, when the breast is either stimulated from suckling or we hear a child crying, the oxytocin hormone, which is from your posterior pituitary, is released, and it lets the milk down into the ducts near the nipple. Okay, so 2 different hormones are in play there. So let's look at some of those structures. If we look at a side view of the breast, okay, so we have the lobes, which have the lobules in them. And they have taken one of these little lobules and blown them up. Okay, and you can see in a non-lactating female, these are the ducts and they're closed. In a lactating female, will actually get distension of those little lobules and milk will be stored. And the milk is stored higher up in the breast, as I mentioned. The creation of that milk is created or perpetuated by prolactin. It'll be stored there until the letdown reflex happens from the release of oxytocin, where milk will be let down closer to the nipple into these lactiferous ducts, where we can then secrete the milk for our children. Underneath the ducts themselves, there's also fatty tissue, and then there's the muscles of the chest wall. And I bring that up because with breast cancer, we know that it can spread out into the lymphatics, but also into this fat, and also to the chest wall muscle, okay, which would be your pectoralis muscles. I could talk about anatomy and physiology of the reproductive system forever, but we need to move into the bulk of what we need to learn here, which is reproductive disorders. If you would like, I also have my anatomy and physiology, reproductive, and pregnancy lectures on YouTube. If you'd like to pop over there and see any of those, they're such fun lectures. There's so much more I could go over, but alas, we only have so much time. So many things can go wrong with reproductive organs. So many things can go wrong with pregnancy. It always amazed me when I was pregnant how much was happening and how much went right when so much could go wrong. So anyway, let's talk about some of these diseases. We're going to talk about a whole bunch, and a few congenital abnormalities we're going to talk about are epispadias, hypospadias, and cryptorchidism. Okay, cryptorchidism. Sometimes my tongue gets ahead of my head, I'm sorry. So, these are 3 disorders that probably sound fairly familiar to you. Epispadias is when the urethral meatus occurs on the dorsal or the top of the penis. This is congenital, so this will be happening in the mother's stomach. It can affect females, putting that urethral meatus in the clitoris. I think it's more prone to happen in males. It'll cause, obviously, urination problems in male and sexual dissatisfaction in women since they have the meatus in their clitoris Ugh. So men may not be infertile, but they may have trouble. Remember the angle I was talking about for ejaculation to happen, for pregnancy to best happen with the anteverted uterus. It's the same premise with Hypospadis. If it's not at the right angle, it won't go into the uterus as effectively. So both can have an increased risk for UTIs. Hypospadis can be affiliated with bladder exstrophy. Sorry. Sometimes my mouth just doesn't work. Okay, if they're not words that I use on a regular basis, it takes my brain a little while. I think I get talking so fast. So this is when the bladder protrudes out of the stomach, and obviously this would have to be fixed surgically. Now, on the other side, we have Hypospadis underneath the penis on the ventral surface. It can extend the length of the penis. So older maternal age, obesity, fertility treatments, and hormone therapy can all lead to this, but it can also just happen. Okay, so one or both testes, when they don't descend, is undescended testes or cryptorchism. Oh my goodness, I can't talk today. I notice I do better in the morning when I've had my coffee. It's now 1:05 in the afternoon. My brain doesn't work as well. Okay, we're going to go with undescended testes or ectopic testes. And this is bad because if the male's testes don't descend, they stay in the abdomen because it's actually where they develop in a similar location to the ovaries. If they don't descend, there's actually a ligament that will pull them all the way down through the inguinal canal and into the scrotal sac from the abdomen. If that does not happen, there can be fertility issues with that male. So let's practice a few of these. Okay, this is an obvious one. And this is going to be undescended testes. And you can see the testes will actually begin in the abdomen. They can get stuck partially in the inguinal canal. And there's two rings to the inguinal canal. So what happens with the testes is they'll actually come through that inguinal canal. They could get stuck at the top of the inguinal canal or at the bottom of the inguinal canal. And that's what it's talking about. It's near what's called the external ring. If you just remember inguinal canal, that's fine. Now, it can also enter the scrotal sac, but not descend fully. So there are some variations on undescended testes. This may be a little difficult to see. If you take just a minute and look. Okay, bladder exstrophy in girl, this would be a girl. And there's the exposed bladder. And they're actually born with an exposed bladder, so this would be the surgical consult for sure. This one is going to be Hypospadis. I think that one's pretty obvious. Last but not least, what do you think of this? That would be Hypospadis. All right. Okay. Now, infertility can happen in both males and females, and if someone is unsuccessful after a year, they should consult a fertility expert. With males, they may have a decreased sperm count. There could be hormone issues. There could be testicular issues, which are either blocking the sperm or not creating a cool or a warm enough environment for the sperm. So there are several issues with that. In females, there could be an ovulation issue, hormone issues, physical obstruction. I mentioned earlier to remember how thin the fallopian tubes are. If a female gets pelvic inflammatory disease or disorder, and that inflammation comes up into the fallopian tubes, it can actually cause a scar tissue in the fallopian tubes, which can impede her fertility. So that's why I mentioned that earlier. So disorders of the testes and the scrotum are usually structural, and that's what we're going to talk about. They can be acquired or congenital. Most of them are pretty easily fixed. So let's talk about hydrocele, spermatocele, varicocele, and testicular torsion. Hydrocele. When we look at the testes, there's actually serous layers in the testes, which I didn't go into because I didn't think that we had to get into that much detail. If fluid gets accumulated between the layers in the testicles or along the spermatic cord, it is considered a hydro, which would be water, seal, or fluid-filled cyst. It can infect one or both testes. It can be congenital, inflammation, infection, trauma, tumor, anything that you could really think of. This is different from a spermatocele, which is actually a sperm-containing cyst. This will be between the testes and the epididymis, which is that comma-shaped structure in which the sperm mature. So they might have a painless, small, movable cyst. You could transilluminate it if you wanted to. I don't really see the point, but anyway, your book had that down. So unknown cause, but most likely it's probably a blockage somewhere. Could be an infection, inflammation, or trauma, but I would go to a blockage because it's filled with sperm. So varicocele is a dilated vein in the spermatic cord, and it can go down, I believe, too close to the testicles. So this is just like distended veins in the leg. There's valve issues. Blood does not get pushed out of that vein. Blood will pool in that vein and distend them, just like varicose veins in the legs. It could be a congenital defect. It could just be an obstruction. It's most common cause for low sperm count. Let me tell you why. Because the veins in the testicles run right next to the artery. And in the testicular artery, we're bringing blood to the testicles to feed and nourish the testicles, and the veins take blood away. Well, the other thing that the veins do is they cool the testicular arteries. They go right by the testicular arteries and draw some of the heat from them. So if you have a varicocele, you don't have a fully functional vein that can draw the heat from the testicular artery, keeping the proper temperature in the testicles, and that can cause a low sperm count. So it's most common in the left testicle. I would think, I bombed around the internet. Honestly, I couldn't find a quick, easy answer. But my guess is that the left testicle has more of a difficult time getting the blood out into the vein it needs to drain to. So it's more prone to pool on that side. The left testicle is also furthest from the heart. So it may take more pressure to push the blood out of those testicular arteries on the left than the right. Is it a big deal? No. Is it in the literature? Absolutely. Ooh. Okay. So, manifests as a bag of worms, feeling in the scrotum and a scrotal heaviness. So, now testicular torsion is going to be abnormal rotation of the testes on the spermatic cord. The spermatic cord is the area in the male through which the vas deferens, the testicular artery vein, and artery go, and nerves as well. And there's a fascia covering it. So it creates like a little tube. So the testes can get turned and cause testicular torsion. So this can be from trauma. It can just occur spontaneously. Manifestations would be sudden scrotal edema and pain. So let's practice some of these, okay? Yay. All right, what do you think you got here? Oh, it's listed on there. I'm not doing a very good job today. Spermatocele. Darn it. Okay, so it'll be right on top near the epididymis, between the testes and the epididymis, and that would be full, so that would be your key as to how you would know it, of sperm. Okay, I'm hoping the next ones are blocked. Darn it. Okay, this one would be, if you look at normal on the left, abnormal on the right. Those veins are tortuous and distended. Yes, this would be a varicocele. This one. The name's on here too. I'm going to pause the tape after this, make sure I got all the rest of them done. There's going to be a hydrocele. Darn it. Okay, there you go. Fluid fill. I'm going easy on you this time, right? Hydrocele. But you can see the difference between that hydrocele is it's going to be full of fluid, but it's also not going to be near the epididymis. It'll be surrounding the testes in the scrotal sac because it's going to separate the walls of the scrotum. This is going to be that testicular torsion. That was pretty obvious. All right. So let's talk about some menstrual disorders. Simple, straightforward. Amenorrhea, dysmenorrhea. Dysmenorrhea is painful. Amenorrhea. A always means without. A meaning absence or without something, absence of menstruation. So amenorrhea we would see, say, in anorexic females because they don't have enough of estrogen and progesterone hormones to regulate their menstrual cycles. They'll stop having it. Dysmenorrhea would be painful menstruation. We could see this in females who are just starting their menstrual cycle. For example, females that are getting closer to menopause or females with endometriosis. We're going to go over some of those issues as we move along too. Let's talk about some disorders of pelvic support. This will specifically be in females. And females have several things in place to keep the support of their pelvic organs, including the bladder and the uterus and the rectum. There's muscles, ligaments, and fascia, and I went over those when we went through the anatomy. Over time, unfortunately, things break down. Our bodies don't stay healthy and young forever. So these support mechanisms start to break down as well. Childbirth can also cause, can't even say childbirth today, issues in a female, trauma, hormonal changes, and like I said, things just break down as we get older. Organs can shift out of their normal position and or move through other structures, and we're going to go through these examples here. Cystocele is when the bladder protrudes into the anterior wall of the vagina. So this could be weakened pelvic support, damage to the vagina during childbirth, for example, recurrent cystitis, inflammation, infections can cause issues as well. Having lifting. Recurrent cystitis, is a complication that happens if you have the cystocele. Okay. Rectocele is when the rectum protrudes through the posterior wall of the vagina. And if you pause for just a moment and think of the anatomy in your head, you could picture the bladder in the front, the uterus on top of it, the vagina, and then the rectum is right behind the vagina. Okay. So causes of rectocele is things that can strain the fascia and menopause. Isn't that great? As those hormones start to wax and wane. Uterine prolapse probably sounds a little more familiar, and this is when the uterus or the cervix descends into the vagina, and there's different classifications. First degree would be when the cervix has dropped into the vagina. Second is when the cervix is apparent at the vaginal opening. Third degree is when it bulges through the opening and lower. This again obviously would happen if there was a stretching or weakening of that pelvic support. And don't forget, that's with the serous membranes that hold the uterus in place, as well as the urogenital diaphragm that I showed you earlier. So, some other disorders of the uterus that can happen. And these two that we're going to give you can be from hormonal imbalances. It can be benign. They can turn malignant. These aren't really infectious. The endometriosis and leiomyomas could be congenital. Okay, so I think these lean more towards hormonal imbalances, these two. Endometriosis and leiomyomas. Oof, big words, right? Endometriosis probably sounds pretty familiar. I think most people who are clinical and non-clinical know about this. And this is when the endometrium, or that inner lining, starts to expand, and it grows in areas outside of the uterus. Most commonly goes up to the fallopian tubes and the ovaries. Where the ovaries and the fallopian tubes meet with the fimbria, there's actually space. The fimbria just lightly sit on the ovaries, so this endometrium can just continue on and get at that point into the peritoneal cavity, out into the abdominal cavity, and it can go all the way up to the liver. Believe it or not, it's amazing. This abnormal endometrial tissue continues to act as it would normally do so during menstruation. Blood becomes trapped and irritates surrounding tissue. So there's different theories. Menstrual blood just sort of sneaks out. Maybe the bloodstream carries these endometrial cells to other sites. Predisposition, genetics. I think the first one is one that I've heard the most, is that those endometrial cells go up and through the fallopian tubes, get out into the peritoneum, which is your abdominal cavity, takes root and starts to grow. So I did keep some complications and manifestations on this one because I do think this is a fairly common disease. Pain, you can get cysts, scarring, adhesions. Even if they go in and clean it out, they can regrow. Infertility, because don't forget, if the endometrial cells go up into the fallopian tubes and block it, those will scar, and a female cannot release eggs to be fertilized by a male sperm. Painful periods, heavy periods, pelvic pain, infertility, pain during or after intercourse are all manifestations of endometriosis. Awful, awful disease. Leiomyomas, and then we're going to do a few let's practices. These are firm rubbery growths of the myometrium. Okay, so the myometrium is that middle muscular layer, and these are very common benign tumors in females. So, don't really know the cause of it, but it is definitely affiliated with hormones. They grow and shrink according to hormonal release. So when there's more estrogen, they grow. After menopause, they shrink. The locations can be submucosal. Submucosal means it's just underneath the endometrium. With the endometrium, that's the inner lining. So these are the ones that can cause problems with the female getting pregnant because they disrupt that endometrial lining. And if it does embed, it can actually keep it from staying embedded in that endometrial lining. Subserosals on the outside of the uterus, underneath what are known as serosal membranes. So those are really not a problem. And they can either be embedded on the outside, or they could be pedunculated, which means they're on a little stalk of connective tissue. Intramural means that they are in the myometrium or in the muscle itself. These can also cause a little bit of problem with pregnancy. Okay, don't cause problems with fertility, but do increase the risk of spontaneous abortion, as I said, and preterm labor, especially the ones that are on the internal lining. Okay, so those submucosal and even the intramural can cause problems. Can range from microscopic to weighing several pounds. These can get pretty large. I have one of these, and when I was pregnant, almost fully pregnant, I could palpate it, and it was a few inches across. Of course, I'm sure it was stretched out during my pregnancy, but you can palpate them. All right, let's practice. Hopefully I have everything covered this time. All right. Female genital disorders. So what we're looking at here, if we take a minute, you can see the uterus with the cervix dipping into the vagina. Okay. So there's the cervix. There's a cervical os or opening. So this would be the endometrium. This would be the myometrium. Okay. And then this would be those serosal membranes on the outside. So what do you think we have here? These indeed are multiple leiomyomas. And if we take a look, what do you think this one is here on the inside? So we'll go with 1, 2, 3. What do you think 1 is? That would be submucosal. 2, subserosal, which is on those serous membranes on the outside of the uterus. I think I made this guy 3. These are your intramural fibroids. Now, in addition, the one we haven't looked at yet are the pedunculated. So you could get pedunculated, subserosal, and I won't ask you about the pedunculated. I just want you to know subserosal, submucosal, and intramural. Okay, and this is pedunculated submucosal. Some really good examples. Leiomyomas. This is a little tough to see. Take a minute and see if you could get yourself oriented. You can pause the tape if you like. I'm going to move on. These are also leiomyomas. Haha, trying to trick you there. This is what they look like in an actual uterus itself. Usually there's quite a few in a female. Take a minute and look at this. What do you think this might be? It's showing mild, moderate, severe. This would be, you got it, stages of endometriosis as it's close to the uterus and the ovaries. As I said, it can sneak out here. Pardon me. So these are the fimbriae here, and they just lightly touch the ovaries. So what can happen is these endometrial cells are tiny, they're microscopic, they can just sneak out and get into the abdominal cavity and spread their way up. All right, what do you think this may be? This is going to be an example of cystocele. What do you think is going on here? So here is, these are actually a couple of examples. So let's get you oriented. Here's normal anatomy here, okay? So if we take a look at this picture, what do we think is going on here? If we take a look at this picture, what do we think is going on here? And if we take a look at this picture, what do we think is going on here? You can pause the tape if you like. I'm going to remove these. This would be prolapsed bladder or cystocele. This lower left would be, okay, prolapsed bladder or rectum or rectocele. This one I think is going to be obvious. This will be uterine prolapse. All right, I thought those were good examples. One more here and we will take a break. Another example of something that we've already looked at. And this is going to be rectocele as well. Okay. All right. That is our next little grouping of reproductive dysfunctions, anatomy, and physiology. As always and forever, if you have any questions, shoot me an email. Let me know. I'd be happy to get back to you. See you in the next video.